Although some of the principles of examining children are very similar to adult examinations, there could be some important differences in both outline and the detail. As a general rule, please do not consider that children are just some small adults and that the pattern of disease, the approach to the examination, and the content of the examinations are quite different in children, and it may be different based on different age groups also. The examination also changes as the children develop, it gets older. Eventually, it is similar to, will become similar to the examination of an adult. Nurses working with children should have a good knowledge of normal developmental milestones as well as routine physical development and findings at different ages. Some general pointers of interviewing children and their parents will be that it is important to have established a rapport with the parents and the child when taking the history. The approach to the examination will be determined by the age, level of development, and level of understanding of the child. Inspection and observation are the most important parts of the examination. Observations can be made while taking the history and establishing the report. And for example, you can observe the child's behavior and level of awareness and take this into account with the parents or by listening to the parents' own reports. Consider if the child's appearance is unusual at all and in what way that is. Note the shape of the head, the mold of the ears, position of the eyes, body proportions, posture. Note whether the child looks like the parents also. Establish whether there are any recognizable major or minor abnormalities. Record the nature and distribution of skin lesions and rashes. Note the color and shape and position of bruises at present. If they have suspicious appearance, consider the possibility of non-accidental injury. It's important to avoid wakening sleeping children. Always approach the child at their level. If necessary, kneel on the floor. It may be impossible to examine an irritable children without provoking crying, and they should be actually carefully observed before attempting any closer examination. You need to start examining peripherally by hands and feet. That this is probably the less threatening type of approaching. Most of all, make the examination fun to help with their anxiety. Sometimes a toy may help. Either one that the child has brought with them or something in your consulting room. Even a pen torch or an ear speculum or rattling a urine container can be a type of distraction. Make sure the child is comfortable and that your hands, stethoscopes, and any other instruments you may use are warm. Ask parents to assist with dressing or undressing children and be aware of sensitivities about that. Please take a moment and stop the presentation here and read through the objectives for this chapter. It's probably a good idea to, if you forgot the differences between subjective and objective data, to refresh your memory in terms of what will include each of those. So most objective data are collected through interviewing the family, the caregiver, and the child. The interview helps you establish relationship with the child and the family by listening and using appropriate communication techniques. You can promote a good interview. Using focused questions and allowing time for answering will help the child and family feel comfortable. Please always choose for a private, quiet setting that will decrease distractions during the interview. Start by introducing yourself to the child and the family caregiver and state the purpose of the interview. A calm and reassuring manner helps establishing trust and comfort. Past experience with healthcare may influence the interview. Both the caregiver and the child should be comfortably. Have yourself and the caregiver seated. The child should be included in the interview process if appropriate. Include the preschool child and the older child in the interview. Use age-appropriate questions when talking with the child, and showing interest in the child and what he or she says will help both the child and the caregiver feel comfortable. Be honest. Whenever you answer the child questions, that will help establishing trust with the child and the caregiver. You may use stories or books written at the child's level in helping him or her to understand, um, and also by using them, you may get a deeper understanding of their thinking or feelings. Listen attentively to the child's comments and make the child feel important in the interview. Um, Adolescents can provide information about themselves, obviously, and interviewing them in private often encourages them to share information that they might not contribute in front of their caregivers. This is especially true when asking questions of a sensitive nature, such as information regarding the adolescent's drug use or any type of sexual practices. The reason for the child's visit to a healthcare setting is called the chief complaint. Um, in a child setting, this reason might be just a routine check, like an annual healthcare check, or immunizations, or it can be an illness or other condition that might be the reason um, for presenting to the office. The caregiver's primary concern is his or her reason for seeking health care for the child. To best care for the child, it is important to get the most complete explanation of what brought the child to the healthcare setting. Repeating the caregiver's statements regarding the child's chief complaint helps ensuring a correct understanding of what the caregiver has said. To help discover the child's needs, try and elicit information about the current situation, including the child's symptoms, when they began, how long they have been present, a description of the symptoms, their intensity and frequency, if there was any treatment to this time, and what was the result of the treatment. Ask questions in a way that encourages the caregiver to be specific. This is also the time to ask the caregiver about any other concerns that they may have regarding the child. While collecting subjective data, ask the caregiver or child questions about each body system. Gathering this information helps focus the physical examination and to get an overall picture of the child's current status. Review the body system involved in the chief complaint in full detail. As the other body systems are discussed, reassure the caregiver that the chief complaint has not been forgotten or ignored in the process. Question number 1. At what age should children be included in the client history interview? A. Toddler. B. Preschool. C. School age. Or D. Adolescent. The answer is B. Starting at the preschool age, the child should be included in the client history interview. All the information that you observe directly are called objective data, while all this objective data um, will be collected and will be included into the baseline measurements of the child's visit. That will include height and weight and temperature, pulse, respiration rate, and blood pressure. Data are also collected by examination of the body systems, and often the examination for a child does not proceed in a head-to-toe manner as in the adults, but rather will be in an order that takes in consideration the child's age and their developmental needs. Aspects of this examination that might be more traumatic or uncomfortable for the child should always be addressed last. The observation of the infant's behavior, um, it's critical, and mainly because infants cannot articulate um, their information regarding their health status. Look for any types of clue they may indicate an illness in a child, as a child being quieter than usual or less active than usual, crying or acting uncomfortable, any refusal of eating or exhibiting behaviors that are different than expected for the child's level of development. The child's height and weight are helpful indicators of growth and development. Um, those should be measured and recorded each time the child has a routine physical examination. And for those of you that have children, you know that that happens. As well, um, so these measurements must be charted and they will be compared with the norms for the child's age. Plotting the child's growth on a growth chart gives a good indication of the child's health status. This process gives a picture on how the child is progressing and often indicates wellness. Although the charts are indicators, the size of other family members, the child's illness, the general nutritional status, and developmental milestones must be also considered. Growth charts and Denver developmental tests are an important part of the objective data. So usually, we start by measuring the head circumference only up to 2 years of age. The vital signs will also be determined at each visit. The values will be evaluated and will be compared with previous values. In addition to that, those are actually compared with data of children of the same age. Um, Temperatures can be taken by oral, tympanic, temporal, rectal, or axillary methods. Make sure that you're using the method that is appropriate for your patient, for the age and their development. In addition to that, make sure that the method of measuring the temperature will address the chief complaint. Um, so to speak, do not measure an oral temperature if the patient is coming with a chief complaint of vomiting, or a rectal temperature if the patient is coming with a chief complaint of diarrhea. For infants and small children, we will always measure the apical pulse. In some extreme cases, we may use cardiac monitors, and the respiration needs to be counted for a full minute, and this when the child is lying or sitting quietly. For infants and in some special situations, we may use apnea monitors. This chart presents a rough shortcut for the normal values that you can see in different age groups. And you can see how respiratory rates are decreasing while the age increase, as well as the awake heart rate and the sleeping heart rate. So all those will decrease. The smaller the body, the higher the respiratory rate and the heart rate, both awake and sleeping. On the other hand, if you're looking at the systolic blood pressure and the weight, you can see how those will increase with the increasing age. For children 3 years of age and older, the blood pressure monitoring is part of the routine and ongoing data collection. We'll take a baseline blood pressure for a child of any age who presents for the first time to a healthcare facility. Before we are performing that, we need to explain the procedure to the child in terms that even a young child will be able to understand. We may start by taking the blood pressure on a stuffed animal or a doll, just to show the child what is involved in the procedure and make them become comfortable and not being scared of the equipment. Rectal temperature may be taken in children, but usually only if any other method cannot be used. The infant's respiration, again, needs to be counted for a full minute due to some normal irregularities, especially in very young children. We'll need to also observe the chest of the infant or young child for retractions that may indicate respiratory distress. We'll pay attention and we'll note any type of retractions that are substernal, below the sternum, subcostal, below the ribs, intercostal, in between the ribs, suprasternal, above the sternum in the notch, or supraclavicular, above the clavicles at the level of the shoulders, the upper shoulders. Along with other objective data, we'll collect data about the level of oxygenation of the child. And we are doing that by using pulse oximetry that will measure the oxygen saturation in the peripheral arterial blood, the oxygen that is connected to hemoglobin in the periphery. So unlike the head-to-toe that we are doing in the adult, um, again, the examination of the child will go from the less traumatic areas to those that will make the child feel more uncomfortable or may cause pain to the child. Along with the examination, we will perform a range of motion. We'll both observe it and we'll try and perform it in the head and neck, and we'll also examine and observe the facial features for balance and symmetry. Moving down with the head to toe, when we are looking at the chest, we'll measure the chest and we'll observe the respiratory characteristics. The heart sounds will be listened to the point of maximum impulse, and the pulses throughout the entire body needs to be assessed in all the stations that we are able to do that. The abdomen is assessed for any type of abnormality, starting by examination, auscultation, followed by palpation. Vowel sounds, when we perform the auscultations, need to be listened in 4 quadrants and to look for enough time to make sure to make a good notice of vowel sounds. We'll examine the genitalia and the rectum, as well as the back of the child and the extremities. In terms of the neurologic status, collecting data related to the neurologic status can be very complex and probably the most difficult part of the physical examination. All the body systems function in relationship and under the command of the nervous system. The healthcare provider will assess the neurologic status of the child by performing a complete neurologic examination. And during this examination, we need to include a detailed examination of the reflex responses as well as the functioning of each of the cranial nerves. And in this, somehow we are similar with the examination of the adult. The healthcare provider will also perform a neurologic and the full neurologic examination for any child that had a head injury or a seizure or for any child that has a known metabolic condition. And in this will include diabetes and any other known metabolic conditions. In patients, in children that have a history of drug ingestion, severe hemorrhage or dehydration, because all those conditions might affect the neurologic status. So by doing that, we are actually determining the level of child's neurologic function. As the nurse, while you're collecting the data, you may be responsible for also using neurologic assessment tools as the Glasgow Coma Scale. And while doing that, you're actually monitoring a child's neurologic status after the initial neurologic examination in terms of looking for elements that may show that the neurologic status is improving or actually degrading, and that will need an intervention. The use of a standard scale for monitoring permits the comparison of the results from one time to the other and also maintains a certain standard, standardizes the examination from one examiner to the other. And you have here the pediatric Glasgow Coma Scale that we can use, and we are evaluating the eye response, the best verbal response, and keep in mind that that will be different for children under 2 years of age and those that will be between 2 and 5 years of age. After that, it's pretty similar to the adult, and we'll evaluate also the best motor response. And you can see that we are giving a score between 1 and 4 for the eyes, between 1 and 5 for the best verbal response, and between 1 and 6 for the motor response. Question number 2. Tell whether the following statement is true or false. The reason rectal temperatures are not recommended for newborns is that intestinal perforation is common. The answer is false, and the rationale is that rectal thermometers are not desirable in the newborn because of the danger of irritation to the rectal mucosa. It is also not desirable for children who have had rectal surgery or who have had diarrhea to have their temperature taken rectal. Question number 3. During the physical examination of a child, where is it most important to assess for signs of child abuse? And your options are head and neck, chest, genitalia, or extremities. The answer is C, genitalia, and the rationale for that is because you need to be aware that unusual findings such as bruising in the soft tissue, bruising with a clear outline object, or unexplained injuries might indicate child abuse and should be further investigated. Also, any type of injuries in areas that usually were not going to be injured in a normal play or as an injury as a result of an accident in a child is injuries at the level of the abdomen or the upper chest, anterior chest. Those need to be also evaluated carefully and maybe further investigated.